morning. Today we will continue the cardiovascular system. We have dealt with blood as part of the cardiovascular system, and then day before yesterday we were dealing with the heart, the pump for the cardiovascular system, and today we're going to deal with the blood vessels. The blood vessels are the tubes that carry this blood, and the blood is pumped into these blood vessels by the heart. So the blood vessels are in the form of arteries, capillaries, and then veins. So the arteries, as we mentioned last time, they carry the blood away from the heart, while the veins, they return the blood to the heart, and the capillaries is the exchange compartment where there is exchange between the blood and the extracellular fluid. So this system is so intricate, and there are a lot of vessels here included, especially the capillary bed where exchange of material takes place. The arteries that carry the blood from the heart, as we will see now, they are in three different types. We have elastic arteries, which are conducting, and we have muscular arteries, which are distributing, and then we have arterioles. These, the arterioles, they are the small arteries that are present just before the capillary bed. And then the capillaries, and then the blood is collected from these capillaries into small veins, which are called venules, and the venules will collect to form veins that return the blood to the heart. In addition to that, we have some blood vessels, which are called the Vasa Vasorum, which means Vasa Vasorum means blood vessels to the blood vessels, because larger blood vessels, they have very thick wall, and they cannot depend on the blood that is present inside them to supply all the cells because of the thickness of the wall. So they have small, tiny blood vessels in the wall of the blood vessels. Like an example is the coronary circulation, because the heart is in fact a modified blood vessel, let's say, and the wall of the heart itself, the myocardium of the heart, is supplied by blood vessels, as we mentioned last time, the coronary circulation. Unlike the coronary circulation, or just similar to the, not exactly similar, but like in one way or another, it is similar to the coronary circulation. There are the large blood vessels, like the aorta and the large branches of the aorta. They have small, tiny vessels that supply them. And these are called the Vasa Vasorum. These cannot be seen by the naked eye. They have to be seen under the microscope. In general, the blood vessels, which are tubes, they are formed of three tunics, or three coats, or three layers. Like tubes in the body in general, they are formed by multiple layers, and each layer has a certain and a different function. You have seen, for example, in the respiratory passages, there is a lining mucosa which has certain function, and there are cartilages, there are smooth muscle fibers, and there is connective tissue. So each one of these layers serves a specific function. The same thing here in the blood vessels. In blood vessels, we have three principal layers, and which are called tunicas. So we have the deepest one, the innermost one, is called the tunica intima, and then the middle one is the media, and the outer one is the tunica externa, or sometimes they call it the tunica adventitia. So three basic tunics for each blood vessel. Whether the blood vessel is an artery or a vein, it has this basic structure. So the tunica media is formed by a simple squamous epithelium. This is the simple squamous epithelium, which is here. It has a special name. When it lines the blood vessel, it's called endothelium. When it lines the heart, as we mentioned last time, it's called the endocardium. So here it is called endothelium. It is simple squamous epithelium and lies on basement membrane, and this will provide a smooth it provides the smooth flow of blood inside the blood vessel. If this endothelium is injured, then this will initiate or starts the process of blood clotting. So we need a very smooth surface that is provided by these endothelial cells, and these endothelial cells, they are the only lining of capillaries which have very thin wall, therefore, and so exchange of nutrients can take place between the vascular compartment and the interstitial compartment. The middle tunic is the tunica media, and it consists of smooth muscle fibers and connective tissue in the form of elastic fibers or in the form of collagen fibers. But the important thing here is that it has smooth muscle. It's unlike in the heart where there's cardiac muscle fibers. Here there are smooth muscle fibers. These are circularly arranged, so they can control the lumen of the blood vessel by their contraction, and therefore they are controlled by the autonomic nervous system, which causes either vasodilation or vasoconstriction of these smooth muscle fibers. In between these smooth muscle fibers, there is a variable amount of connective tissue, either in the form of collagen or in the form of elastic fibers. We will see, like in the elastic arteries in a moment, we will find that in the elastic arteries we have a lot of elastic fibers, unlike in the muscular arteries, and we will compare the difference in function between these two types of arteries. So there is a tunica intima of endothelial cells mainly, which provide a smooth, slippery surface, and there is a tunica media, which is made of smooth muscle fibers and connective tissue in the form of elastic and collagen fibers. And then there is a tunica externa or adventitia, which contains again connective tissue. And in thick blood vessels, it contains small blood vessels for the blood vessels, the Vasa Vasorum. So 3 tunics in basically. Now the elastic arteries, again, they have the same basic structure of a blood vessel. These are the largest diameter arteries. They include the aorta, the ascending arch, descending aorta, and the major branches of the aorta, which we are going to study today, like the brachiocephalic trunk, common carotid arteries, and beginning of the subclavian arteries. These all, they have more elastic fibers in their wall. And the reason for that is that when during ventricular diastole, the presence of many elastic fibers will allow these blood vessels to distend, and then elastic recoil. When these elastic fibers are extended, then they are going to contract again. This is what we call elastic recoil. Elastic recoil takes place during ventricular diastole, when the ventricle relaxes, and then elastic recoil here in the wall of this great vessel will maintain a continuous flow of blood. Even when the ventricle is not contracting, when the ventricle is relaxing, then the elastic recoil will maintain the pumping of the blood in the great vessels. That's why we have these elastic arteries. Of course, blood, just to remind you, the blood will not be able to return back to the heart when the aortic arch is contracted, or when there is elastic recoil, let's say, of the aortic arch, because of the presence of a valve here, a semilunar valve, the aortic valve, which prevents return of blood into the ventricle. So the blood will continue to be pumped away from the heart. This is a cross-section of an elastic artery, of a muscular artery. Most of the arteries of the body, the named arteries of the body, are muscular arteries. So you can see here that this is the lumen of the artery. It contains red blood cells and white blood cells, a couple of them here. So it contains blood in the lumen. And then there is the tunica intima, which is difficult to be seen because it's only a single layer of simple squamous epithelium lying on a basement membrane. So it's very, very thin. And then we have a layer here, this layer, which is Probably this is the thickest layer here of the muscular artery. It's formed of smooth muscle fibers. These are smooth muscle fibers. If you remember the histology of smooth muscle fibers, they are spindle-shaped and they have oval nuclei. So these are smooth muscle fibers. They are circularly arranged in the tunica media. Most of the tunica media is formed of these smooth muscle fibers. There are some elastic fibers. You can see here some elastic fibers which are in the form of an elastic lamina, and there's another elastic lamina at the other boundary. So the boundaries between tunica media and tunica intima, there is a layer of elastic fibers, and the boundary between the tunica media and the tunica externa, there is another elastic lamina, and the tunica externa or the adventitia is made of collagen fibers and fibroblasts. So here, this pinkish area here, it's collagen fibers, and the nuclei which you see are not smooth muscle fibers, they are the nuclei of fibroblasts, the cells of connective tissue that produce the collagen fibers. Here, most of these nuclei, they are of smooth muscle fibers. So these are the three layers of an elastic, of a muscular artery, and they are capable, therefore, because they have a lot of smooth muscle fibers, they are capable of vasoconstriction and vasodilation. And that's why they can adjust the flow of blood. So they are called distributing arteries. Like, for example, whenever there is muscular activity or in times of stress, they will divert the blood to the muscles to prepare them for fight or flight, and they will contract in case of for example, the GI tract. So, so that not much blood will go into the gastrointestinal tract. So they are distributing arteries because they direct the blood flow. These arteries, they will become smaller and smaller until they form the arterioles. So these are the arterioles. They are small arteries, and yet they have the same tunica intima, tunica media, and tunica adventitia, but they have fewer muscle fibers in their tunica media. But yet, these muscle fibers, in comparison to the diameter of the arteriole, they are good amount. They are in good amount, and they control the flow of blood to the capillary circulation. So this is the capillary bed, the capillary circulation, and as you can see that these arteries, they can cut off the blood from the capillary circulation and transmit it directly to the venules, or they by the presence of smooth muscle fibers in their wall, they can nourish the capillary circulation. So whenever you need more blood in the tissue, then they will control the flow of blood in the capillary circulation because they are located just proximal, just before the capillary bed. And they play an important role in regulating the blood pressure as well. The capillaries, as I mentioned, they are the small, tiny blood vessels. You cannot see them. They are present everywhere. That's why even small wounds, they bleed because of the presence of these capillaries everywhere. And you can see that they are very small diameter, about 10 micrometer in diameter or even less. That's why sometimes the red blood cells, if you remember, they have to squeeze themselves inside the capillaries because they are sometimes even narrower than the diameter of the red blood cell. So, and they are lined by simple squamous epithelium. You can see it here, lying on a basement membrane, so that the wall is very thin and exchange of material can take place, either oxygen or nutrients between the blood and the extracellular compartment, or the waste products will pass from the extracellular compartment and carbon dioxide return back to the blood. So structurally there's no smooth muscle fibers here. There's no tunica media, no tunica externa. It's only tunica intima, which is simple squamous epithelium, endothelium, surrounded by a basement membrane. No elastic fibers, no collagen fibers, no smooth muscle fibers whatsoever. And as I said, that the blood that passes into this capillary bed is controlled by the arterioles. So if the organ or structure is not that much functioning at that time, then the blood will bypass the capillary bed and will go directly back into the veins and return back to the heart. We don't need to waste that blood passing through the capillary circulation at the time when the organ is not working at that time. Capillaries are divided into three types. So we have either continuous capillaries, and here they don't have gaps in the endothelial cells, and there's all the intercellular spaces. They allow the passage of material between the blood and the extracellular compartment. Some of these continuous capillaries, actually many of these capillaries in the body are continuous. Some of these capillaries, the continuous capillaries, they have tight junctions in the intercellular clefts. Very tight junctions. Remember the type of junctions that are present between cells. We have tight junctions, gap junctions, desmosomes, and so on. These are tight junctions are present between these cells, like for example in the brain. So they act as what we call blood-brain barrier. We remember we mentioned about the blood-brain barrier before. We said it's the tight junctions between the endothelial cells that are present between the capillaries of the brain, and this will prevent the passage or the free passage of some drugs and substances from the blood to the brain. It must be controlled by the endothelial cells. So these are continuous capillaries, but in many other places in the body, we have what we call fenestrated capillaries. As you can see here, that there are fenestrations, there are pores in the plasma membrane, and this will allow a readily exchange of substances between the blood and the extracellular compartment. As an example, for example, here is the kidney. The kidneys, and the kidney, we are going to study the kidney later on, and you will find that the blood is going to be filtered in the glomerulus of the kidney. So you need the capillaries to be fenestrated for easy filtration of the blood. Or the other way around, for example, in the endocrine glands, if you remember, we said that the endocrine glands, they produce their product into the circulation. So therefore, in many endocrine glands in the body, if not all the endocrine glands in the body, the type of capillaries that they have is fenestrated capillary, to provide easy access of the secretion of the gland, of the hormone, into the blood. So the endothelial cells will have pores, but the basement membrane is intact. Now the other variety of capillaries is called sinusoids, and they are larger in diameter to start with. They are fenestrated, but as you can see here, the fenestrations are very big. If you compare that with these fenestrations, in some places these fenestrations even allow the RBC to pass through. Okay, and not only the plasma membrane is fenestrated, but even the basement membrane, the surrounding basement membrane, is also fenestrated. So these fenestrated or these sinusoids, as an example, they are present, for example, in the bone marrow. So in the bone marrow, because the bone marrow produces blood cells, so it requires big sinusoids to allow these blood cells to access the circulation. So they have fenestrated capillaries. Very big and fenestrated, that's to say they have sinusoids. Also, they are present in the liver. And in the liver, usually in the liver, these sinusoids of the liver, which we are going to study later on, there are some cells surrounding these sinusoids, or very close, not necessarily completely surrounding the sinusoid, but lying or sitting just close to the sinusoid. These are phagocytic cells, which can phagocytize like bacteria or can remove toxic substances that will be filtered from the blood in the liver. Okay? So these are the three main types of capillaries. Either they are continuous, they could be continuous with or without tight junctions, or they are fenestrated, or they are in the form of sinusoids, which contain big fenestrations as well as a fenestrated basement membrane. So the structure is always related to function. This is about the control of blood pressure. It is actually more physiology than anatomy. I will skip this slide and we'll continue with the venules. So again, to remind you of our journey, we started with arteries, which are elastic arteries, and then muscular arteries, and then arterioles, and then capillaries and capillary bed. And then the blood is going to be collected from the capillary bed into small veins, which are called venules. And these venules, they have tunica media, which contain very smooth muscle fibers, very small amount of smooth muscle fibers, very small amount of smooth muscle fibers. If you compare this venule, for example, to this arteriole, you will find that in the arteriole there is more smooth muscle fibers in the wall, but here there are only few smooth muscle fibers in the wall. And again, there is the endothelium. So the endothelium is present everywhere. And they are going to collect into larger and larger venules until they will become the veins. You can see here a comparison between an artery and a vein. So this artery and vein are almost the same size, but clearly you can see here that the lumen of the vein is larger than the lumen of the artery, that the wall of the vein is much thinner than the wall of the artery, because here you don't need, the blood here is not under high pressure, the pressure is low. This is one thing. And the second thing is that the blood inside the artery is propelled by the contraction of the heart. But here in the vein, actually it will be a problem in returning the blood to the heart. There's no actual, let's say, peripheral heart that pumps the blood back to the heart. Adding to that is that the blood is, in most of the time, is like when I'm standing now, most of the time the blood is returning to the heart against gravity. So how does this happen? It happens because of two things. It happens because of there is a thin wall here in the vein, so that the surrounding tissues, they can pump or they can press on the veins because they are thin-walled, so they are easily compressed, and thus they push the blood. But how come the blood is pushed to the heart and not away from the heart? Because if you if you press on a tube, then the contents of the tube can disperse in either direction. Here, you need another structural component in the vein, which is not present in the artery because you don't need it in the artery, and that is the presence of valves in the veins. So usually the veins, they have valves. Very thin, small valves. They look like the semilunar valves, and they are directed in such a way that they will allow the blood to pass from the peripheral part of the body toward the heart. So the blood will ascend into the vein, like in pieces, in columns, and it cannot return back when it is compressed from the peripheral, from the outside tissue, because these valves will prevent the backflow of blood. Okay? So that's why we need the valves in the veins. The valves in the veins are necessary to return the blood against the gravity to the heart. The wall of the vein, again, as I said, it's thin-walled, and it has very small amount of smooth muscle fibers in its wall, yet there is a tunica media with the smooth muscle fibers, and actually the thickest part of the wall is the tunica externa, the adventitia or the tunica externa. Yeah, this one. It's much thicker than the tunica media. If you compare that with the artery, the tunica media is the thickest wall, and the wall of the artery in general is thicker than that of the vein. So here you can see here how the muscles of the lower limb are acting on the veins in the lower limb. trying to push the blood back to the heart. Okay? When the muscle contracts, the vein can be easily compressed. The reason for that is that it has a very thin wall, as you see here in the slide, and the cross section, and the blood will be pushed only this way because the valves allow the blood to go up, back to the heart, and they prevent the blood from returning back to the periphery. If these valves and the veins, if they fail, then the peripheral veins will become distended and will become dilated. See here? This is how the valve works. It prevents the blood from returning back. If these valves fail, as in this case, then blood will return back to the vein. And therefore, the veins will become tortuous. They will become dilated, tortuous, especially here, the veins which are located under the skin in the lower limb, because they are the most veins that require pressure to be of the content of the blood to be pushed back to the heart, and they are always against the gravity. The blood inside them is always against the gravity, or let's say most of the time it's against the gravity. So in people who have problems in the valves, or people who stand for a long period of time, they are more likely to develop the varicose veins. The veins will become large and they can be seen under the skin. They are worm-like. That's why they are called varicose. Varicose means worm-like. The deeper veins are not that susceptible because they are surrounded by or supported by the surrounding tissue, like the muscles. But here, these veins are just under the skin and they are not supported by the muscles. These veins that are present under the skin, actually we need them for the peripheral circulation, for the control of the temperature of the body. That's why you see these distended veins in hot weather, but in cold weather you will not find them or easily under your skin. And they are not accompanied by arteries. They are present in the extremities, in the upper limb and in the lower limb. They function to control as one of the mechanisms that control the temperature of the body. Anastomosis, we mentioned something about anastomosis last time. So anastomosis is that when two or more arteries, they supply the same structure or same body region, and they come to meet each other. So stoma is like mouth, so they are meeting each other mouth to mouth. Anastomosis from stoma. So we have seen an example in the heart, in the coronary circulation, right and left coronary arteries, there is anastomosis. The good thing about the anastomosis is that it provides an alternate route for the blood to reach the same organ when the other route is closed. And this is what we call a collateral circulation. So like, for example, when one of the branches of the right coronary arteries is obstructed, then the left coronary artery can compensate in one way or another. Sometimes it can compensate, other times it cannot, and this will result in myocardial infarction or ischemia, as we mentioned last time. The same thing here in the brain. Probably we mentioned that before, that the brain has two main sources of blood supply, the internal carotid and the vertebral system, and they will meet each other. In other words, they will anastomose with each other at the circle of Willis that is present in the base of the brain. Fortunately, this allows a collateral circulation. But unfortunately, these branches, the branches of the circle of Willis, are actually end arteries. End arteries means that there is no anastomosis. If one of these branches is blocked, then there is no other branch that can compensate. There is no collateral circulation. So when there is the organ is supplied by more than one artery, this is called anastomosis, and it provides a collateral circulation. If it is not, then the artery is called an end artery, and this is dangerous. Circulation could be systemic circulation, like what we described yesterday. Systemic circulation, blood will be pumped from from the heart into the aorta and will be distributed in the body to the capillaries, and then returned by venules and veins and returned to the right side of the heart, right atrium, through superior, inferior vena cava and the coronary sinus. This is what we call the systemic circulation. And these are some of the blood vessels of the systemic circulation. I'm going to pass rapidly through them because most of the time it's just mere memorization. So you have to memorize some of these important branches. There is the ascending aorta, arch of the aorta, and descending. The ascending aorta provides two coronary arteries. We mentioned that last time, that the coronary arteries, they arise from the aorta just above the aortic valve. And then we have the arch of the aorta, has three main branches. One of them is called the brachiocephalic. This is the first branch from the arch. Brachiocephalic, because it divides into subclavian, which becomes the axillary, and the brachial. So it supplies the brachium, the upper limb. That's why it's brachio. And cephalic means head, because it supplies the common carotid artery. So here we have the subclavian and common carotid arteries on the right side, arising from a single trunk. On the left side, each one of them arises directly from the arch of the aorta. So you have three branches. Ultimately, they will become four branches. And then you have the descending aorta, which goes down into the abdomen, passes through the diaphragm, and becomes the abdominal aorta. This is the subclavian artery here. On the right side, it's a branch of the brachiocephalic trunk. On the left side, it's a direct branch of the arch of the aorta. Subclavian becomes the axillary, which is the artery here of the axilla or the armpit, and then it becomes the brachial artery, the artery of the brachium. Okay, and you can feel the pulsations of the brachial artery just in the cubital fossa, just medial to the tendon of biceps. If you contract your biceps muscle, and you can feel the tendon of biceps in the cubital fossa, medial to it, you can feel the pulsations of the brachial artery. And here, the brachial artery divides into radial and ulnar arteries. And again, you can feel the pulsations of the radial artery just proximal to the wrist. That's where usually we use it to measure the pulse. But the brachial artery, we usually use it to measure the blood pressure. So what happens when you measure the blood pressure is that this cuff of the sphygmomanometer is inflated around the middle of the arm. So you are blocking the brachial artery. And then you put a stethoscope just medial to the tendon of biceps, distal to the site of occlusion or of the brachial artery, and then you deflate because you inflate the sphygmomanometer until the artery is completely closed. So there's no blood passing through it. And you try to detect the sound of blood passing through the artery here in the cubital fossa. So as you are deflating the sphygmomanometer, and when the artery begins to open at that time, it's like a hose having water and you are compressing it. When you remove the pressure from the hose, then the blood will pass through the hose but with a sound. Okay? So this sound, you can hear it here in the stethoscope, and this is called the systolic blood pressure. Until a point is reached that the artery is completely open, the hose is complete, there's no pressure on the hose, so there's no sound of fluid or water or blood passing into that tube. And this is called the diastolic blood pressure. And you can detect that by the stethoscope that is located here in the cubital fossa. The common carotid arteries, the name of the common means it divides into external and internal. So at the beginning is a common carotid and then divides into external and internal carotid arteries. Again, as the name indicates, external carotid means it supplies the structures outside the skull, while the internal carotid goes into the skull, and we have just mentioned that it participates in the formation of the circle of Willis. It's one of the two sources of the blood supply of the brain. Internal carotid. The external does not supply the brain. Both of them arise from a single artery, which is common carotid. And then in the abdomen, the aorta has multiple branches, important branches. Some of them supply the kidney, so they are renal arteries, and the others, they supply the gastrointestinal tract. So we have the three groups of vessels that supply the gastrointestinal tract. We have the celiac trunk, superior mesenteric, and inferior mesenteric artery. And here at the level of L4 vertebra, the aorta divides into two common iliac arteries. Okay, two common iliac. Common because each common iliac is dividing into external and internal iliac. If you follow the internal iliac, it goes to the pelvis and supplies all the viscera of the pelvis. The external iliac goes straight down to the lower limb and supplies the lower limb. Here it becomes the femoral artery, the major artery that supplies the lower limb. Last time I mentioned something about stenting and cardiac catheterization. Usually the catheter is passed here into the femoral artery. You can feel the femoral artery in the front of the upper part of the thigh, and they pass the catheter here. The catheter is passed up, backwards and upwards from the femoral to the external carotid, to the common carotid, abdominal aorta, descending thoracic aorta, arch of the aorta, and ascending aorta. And what are the branches of the ascending aorta? They are the coronaries. So under X-ray, they pass the catheter through the coronary, and they can inflate or put a stent or inject a chemical there. That's the route that is taken. It's the reverse of the flow of blood. Okay? And these are the visceral branches of the abdominal aorta, the celiac, superior, and inferior mesenteric artery. You have to memorize them. And here, as I said, the external iliac artery continues into the femoral artery. You are able to feel the pulsations of the femoral artery. Femoral artery goes down behind the knee joint, in the region which is behind the joint is called the popliteal fossa, so it becomes the popliteal artery. Yes?
That procedure you just mentioned, can they do it with the arm as well?
With the arms?
Yeah, no?
Usually, no. No. What they do in the arms is they use the veins of the arms. So if they want to access the venous circulation, they go through the arms. Subclavian vein, brachiocephalic trunk, and superior vena cava. Yeah. Now, the lower extremity, as I mentioned, there's the femoral artery, which will become the popliteal artery behind the knee joint. It's not easy to feel the pulsations of the popliteal artery, but sometimes if you sit cross-legged and you are relaxed, you are not thinking about your muscles, then you will find that, or somebody will notice that your leg is moving, pulsating, because of the pulsations of the popliteal artery. It's very deep in this location, and then it divides. The popliteal artery becomes then the anterior tibial and posterior tibial arteries to supply the leg and the foot. The veins, they drain the entire body. We have superficial veins, I have just mentioned about them, and the deep veins, which are present deep to the deep fascia. And all this venous blood will drain back to the heart. This is about the systemic circulation. About the pulmonary circulation, I think now you are familiar with the pulmonary circulation. It is the blood pumped from the right side of the heart, right ventricle, into the pulmonary trunk, into the pulmonary arteries. This is deoxygenated blood. So they are arteries but contain deoxygenated blood. The blood will become oxygenated in the alveoli of the lung and returns by 4 pulmonary veins into the left side of the heart. This is what we call it. This is the smaller circulation, and it is the pulmonary circulation. It is for the oxygenation of blood. And we have another circulation here. I would like to talk a little bit about it. It's called the portal circulation. In portal circulation, it is produced when, well, generally here, just before dealing with the pulmonary circulation, here, you see, in the systemic circulation, the capillaries, the capillary bed, will form veins, and the veins return back to the heart. In the portal circulation, the capillary bed will form veins, but these veins will again form another capillary circulation. So the portal vein is a vein that is located between two capillary beds. This doesn't usually happen everywhere in the body. It happens in especially two places in the body. One of them is in the liver. So here, this capillary bed, which is located in the wall of the small intestine, where absorption is taking place, is producing veins, is giving rise to veins. These veins head to the liver. They are called portal hepatic veins, or portal hepatic vein, because they collect into a single vein ultimately. And then inside the liver, the vein will branch into a capillary circulation, so that exchange of material can take place between the blood that is absorbed, between the blood that is brought from the intestine to the liver, either to store the substances that are absorbed or to metabolize them, because the liver is the factory of the body. So the structures, so the blood has to pass from the portal vein into the substance of the liver. You need capillaries again. Remember the sinusoids that I just mentioned, large capillaries with fenestrations. So these are the sinusoids of the liver, and then the blood will be recollected again from the liver and returned back to the heart. So here we have systemic circulation, and we have a portal vein between two capillary beds. An obvious example is in the liver, the portal circulation. See here, these are veins. These veins were formed of capillaries which are present in the intestine, in the wall of the intestine. They form these veins, and then they form a single vein, the portal vein, which goes into the liver, and then inside the liver it forms a capillary bed for the exchange of these absorbed substances. This is called the portal circulation. Another portal circulation, we have mentioned about it. It's a very small one, very difficult to find grossly. This one is easily dissected, but the other one is present in the pituitary gland. Remember when we dealt with the hypothalamus and how the hypothalamus controls the pituitary gland, the anterior pituitary? We said that the posterior part of the pituitary is nothing but axons coming from the hypothalamus, but the anterior part of the pituitary is controlled by blood vessels, by capillaries that come from the hypothalamus. Nuclei in the hypothalamus will produce releasing factors, and these pass through capillaries, will form small veins, and then the veins will form capillaries inside the anterior pituitary to induce the secretion of pituitary hormones. So this is another type of portal circulation, a vein between two groups of capillaries. But the most important one here, which can be easily seen, and the first thing that comes to our mind when we talk about the portal circulation is the portal circulation of the liver. So you can see here this portal vein, that it's a very big vein that the liver receives. So when we study the liver later on, when we deal with the gastrointestinal system, we will see that the liver has two sources of blood supply. It's the portal vein and the hepatic artery. The hepatic artery is smaller. It provides oxygenated blood to the substance of the liver, but the portal vein is bigger. It's about 75% of the blood that the liver receives comes from the portal vein. But this is deoxygenated blood. but it is rich in nutrients that have been just absorbed from the intestine. So again, a portal circulation is a circulation between two beds of capillaries. The other circulation here, last one, is the fetal circulation. It's a little bit different from the postnatal circulation. Here we have oxygenated blood coming from the placenta, from the mother, and this blood goes through the umbilicus, through an umbilical vein, and then bypasses the liver and goes to the right side of the heart. Of course, this umbilical vein later on, after birth, it will be obliterated and becomes like fibrous tissue. You don't need it anymore. And then when it goes to the right side of the heart, as you see here, it will bypass the right side and go directly to the left side, because you don't need much of the pulmonary circulation. There is no air in the lungs. So why should the blood go to the lung and then return back to the left side of the heart? There is a bypass here. There is an opening which is called Foramen Ovale. It's an oval foramen between the two atria. So the blood goes directly from the right atrium to the left atrium to be pumped into the systemic circulation. You don't need to have the blood going into the pulmonary circulation. If this opening fails to close after birth, then this will result in what we call an interatrial septal defect, a problem, an interatrial septal defect. Okay, I will not go into details of the fetal circulation, but this is just one example how the blood comes from the mother through structures that are going to be obliterated later on because you don't need them in the postnatal life. Questions? Thank you.